outline what we're going to talk about today. To start with, before I even talk about driving, I'm going to talk a little bit about staging dementia, because that's going to be kind of an underlying concept that we need to understand before we can do the driving part. And then within the driving part, we're going to review the American Academy of Neurology guidelines. Then we're going to break it down from there into various sections that will help us understand how to deal with dementia and driving. There are some objectives. I'd like to point out that identification of high-risk drivers that should no longer drive and directing those drivers to no longer drive should fall within our expertise. That is in our wheelhouse. That is not something that we should have to be able to, at least not in all cases, defer to someone else. So also identification of low-risk drivers that can be cleared. And then we're going to talk a lot about some that are in the middle and how to risk stratify those ones a little bit better. And then we're going to talk at the end about how we can communicate our concerns or our recommendations with the transportation department. So we're going to talk about staging dementia, as I mentioned to start with. And the big picture is that when it comes to staging dementia, it's all about functional activities. It's not, you can do a lot of cognitive testing, and cognitive testing is helpful and it can be confirmatory, but really in the DSM-5, which doesn't refer to it as dementia, it refers to it as major neurocognitive disorder. But in the DSM-5, dementia staging is broken down by the patient's like functional abilities, and it's pretty simple, really. So if you have mild dementia, it's difficulty with IADLs, so complex activities of daily living like housework and managing money, preparing meals. Whereas moderate dementia would be if someone is having difficulty with the most basic activities of daily living, the ADLs, things like dressing, feeding, and toileting. And then severe dementia is someone who's fully dependent. That's the big picture, and honestly, that's enough to operate off of. I'm gonna talk a little bit more about some tools you can use and some other things we can use to help stage dementia for just a second. But that's the big picture, and that's good enough for most cases to know that much. There's a bunch of tools that exist. I put these up here not so you can remember them, just to point out that there are a bunch of staging tools out there that are impractical for use. These are ones that get used a lot in studies. I'm actually going to reference the CDR a little bit later, just for a second, not because it's something you need to know about, but because that was the way the study was done. So a more practical way to try to stage dementia in the office rather than using these tools would be to use tools that we're familiar with, like a Mini-Mental, MMSE, which is Mini-Mental, Slums, or MoCA. And you can add in a FAST, and the FAST is just if you're not familiar with it, that's just a tool that you can use to gauge someone's functional activities, their functional abilities. You put those together, really it's the FAST is what it's based off of, and you can use some sort of cognitive testing to kind of confirm it. And there's a thing called the Functional Activities Questionnaire I'm going to show you real quick. That's just something where the patient's family member can fill out instead of you filling it out to try to help understand what's going on. And if all else fails, you can always consult with neuropsych and they can stage someone's dementia. So cognitive screening tools, I just put this up to point out that these are the ones that are most commonly used. I didn't talk about Slums here, but MoCA is the one I typically use if I'm going to do any cognitive screening, and they are scientifically validated for screening for detection of really not screening for, but detection of dementia. That's what their purpose was when they're developed. The Mini-Mental's been around for a long time. It's copyrighted. It's been well studied. This information is based off of a meta-analysis using 11 different studies looking at the Mini-Mental, and it has good data if you're just using it as a tool to detect dementia. If you use a cutoff score of 23 or 24, your likelihood ratio is good for positive, and if it's net, and it's also good for the likelihood ratio is also good for being negative. So it's an effective tool for that purpose. MoCA is less studied, but it is public domain. It's been around for not quite as long, but they're both scored out of 30, so it's Slums, and you can use a similar cutoff score. One thing to point out that is important to remember when you're using these cognitive tools, though, is that they're Not every patient is the same. Educational level and age will change what you should expect from your patients when they're doing some of these cognitive testing. These cognitive tests, for example, a patient, a younger patient with college education, you would expect their median score is 29, whereas a patient that is 80 with a fourth grade education, the median score is 20. So that is just something to bear in mind when you're using these tools for evaluation. Is there are some variables that make it a little harder to determine if there is dementia just using a set cutoff score. This is just what this is the FAST. This is what the FAST looks like. It's just a tool that you can use to kind of gauge someone's level of dementia based on their functional status. And it's simple to use. It just goes from 1 to 7, and really for today's purposes, you don't need to go past 5 because we're not, if someone's falling into this category, we're not talking about them driving. And we can use this to kind of determine whether someone has mild cognitive impairment or dementia, whether it might be mild or moderate dementia. And that's just a tool you can use to help scale that. And this is I briefly just mentioned, there's a thing called the Functional Activities Questionnaire, and this is something that the patient's family can fill out that can help. And the cutoff score for that is 9, whereas a low score is better and a high score is bad in this case. Never actually even used this, but I point out that it exists. Okay, so I'm moving on from staging of dementia to the real purpose of the presentation today, which is operation of automobiles. And as a disclaimer to start with, I want to point out that this is a discussion of driving recommendations in the context of cognitive decline. There are a lot of other reasons why you should be concerned about someone's driving abilities and privileges. And I'm not talking about that, right? So if someone can't see, like my patient I had the other week that assured me that her ophthalmologist is okay with her driving, but he really wasn't. Or the patient has seizures or whatever might be going on. I'm not talking about those things. Today is specifically about probably the most common reason you'll run into for questioning someone's driving privileges, which is dementia, cognitive issues. Another thing to point out is that requirements and processes for this vary a lot from state to state. Idaho, as you might anticipate, is very hands-off. Idaho puts a lot of it in the hands of us as clinicians to decide what is appropriate. Lets us make judgment calls. The government does not get particularly involved in making any decisions. Other states do. For example, if you just go across the border to Oregon, they are much more involved in the process. They have a whole office in their transportation department that helps even make decisions on these things. The code in the Idaho code that is used to delineate all these things is Idaho Code 49-326. I just want to point out that within that code, there is a statute that says, if a physician submits a report in good faith, no professional disciplinary procedure, no monetary liability, and no cause of action may arise against the physician for submission of the report. So in other words, the patient cannot sue you because you told them because you submitted a report to the transportation department that they should not be driving. That you cannot, if you do it in good faith, you are not going to get in trouble for the patient, as mad as they might be, cannot sue you for recommending the driving privileges be suspended. So, senior driving in Idaho, a couple things that change as patients get older. Starting at age 62, you have to renew licenses every 4 years, and it has to be in person at the DMV in most cases. And that's basically it as far as the transportation department and the Department of Motor Vehicles having additional guardrails as patients get older in this state. That's it. Pretty much anything else is going to come down to self-reporting and you catching it and patients' family members catching it. So that's it. There are a lot of guidelines on driving in dementia within the international community. We're going to talk about our guidelines that we would use in this country here in a minute, but I just point out, no recommendation was endorsed by less than 80% of the guidelines, and 61% of the recommendations were endorsed by more than 90% of the guidelines. In other words, they all basically say the same thing. And they rely heavily on expert opinion because there's not very many studies on this. We'll talk about some of them that do exist. The American Academy of Neurology guidelines from 2010 are the best we got. And what it says a lot more than just this, but this is like a summary of it. For patients with dementia, considering the following characteristics for identification of those at increased risk, unsafe driving. I told you I would bring up later the CDR scale. I'll talk about what that is just briefly for a second. It'll make sense. And that's the only thing here that's level A because it is based on a legitimate study. The rest of this is just kind of, expert advice. A caregiver's rating of a patient's ability to drive as marginal unsafe is something we should pay attention to. Whereas the patient's, I have a slide about that later. And then the rest of this makes sense. And of course, it is just expert recommendations. Obviously, if a patient has a history of crashes and citations, we should be worried. If a patient is reducing their own driving mileage based because they're concerned or because they feel uncomfortable, well, that's a reason to be concerned. This is not something that I put up here for people to remember or even try to have a picture of it all. I put this up just to point out that this is what they use to do this. The one study here, this one here at the top, the CDR scale, is based off of this. The CDR scale is it's a dementia rating tool that's used in studies, not really one that you can see why that you'd want to use in practice. But in this study, this is what they use to grade the dementia of the patients in the study. And basically what it comes down to, you can see across the top, there's 0, 0.5, 1, 2, and 3. What those numbers mean roughly is 0 would be a patient that has normal cognition, 0.5 would equate to mild cognitive impairment, 1 would be mild dementia, 2 would be moderate dementia, 3 would be severe dementia. So when they used this scale and they had patients drive, this was a single study of patients, 75 and older, 2005. And again, you can see this, they scored 0, 0.5, or 1. So that's normal, mild cognitive impairment, or mild dementia. Compared to what they found was compared to drivers with a score of 0, the relative risk of failure driving a test was 82.7, with a very, very tight, very obvious confidence interval. And it was even better for patients with a score, what did I say? Yeah, so it was even better for 1. It was a very, very good confidence interval and very good score for both of them, though. Obviously, what it's saying is that patients that have cognitive impairment were more likely to fail the test. One thing to point out, though, is that even though those confidence intervals sound really watertight, in reality, since 100% of the drivers with 0, 100% of the drivers that had normal cognition passed, that means a lot of the drivers in the other groups could still pass and maintain a significant difference. So in fact, it was only 85 and 75%. So in fact, it was 85 and 76% passed. So it's a good study and it gives us great information, but it doesn't mean that like every patient that had cognitive impairment failed the test. In fact, 85% of the patients with mild cognitive impairment did pass the test on the exam in the study. And this is basically the only real study we have to go off of. So this is the same thing. I already put this up. I'm just going to skip past it since we already looked at that. The second bullet was a caregiver's rating. So self-rating is only reliable if it's fair or poor. This is something that makes sense. We would probably anticipate this, right? So if a patient rates their own driving as bad, I should be concerned. However, if a patient rates their own driving as good, that is not reassuring. Hold on. So in other words, a caregiver rating of marginal unsafe is specific, but not very sensitive. However, oh no, sorry, I was talking about self-rating. So the third one, sorry, the third bullet is talking about caregiver rating. A caregiver rating of marginal and safe is specific. So if a caregiver is concerned, again, I should be concerned. It's better than, so, and if they're not concerned, that's better than a self-rating that their driving is good, but it's really not very sensitive either. Okay, this looks busy. This is actually kind of a algorithm that I put together myself to help visualize this, and I'll walk you through it. It's not as bad as it looks. Just starting at the top though, I wrote CDRs. You could just change out CDR of 0.5 and 1 to be mild cognitive impairment or mild dementia, and CDR of 2 being moderate dementia. And you can see over on the right, if you have moderate dementia, you can just pass go and not collect $200. You just go right to relatively high risk and you intervene pursuant to state guidelines. So if you have moderate dementia, you shouldn't drive, is what it's saying. However, if a patient has mild cognitive impairment or mild dementia, then we got to go through all this stuff on the left to try to better risk stratify it. And we start by going through those same characteristics I talked about before, which is the stuff from the guidelines. Does the patient have citations and crashes? Is there a caregiver that's reporting concerns? Is there situational avoidance? Do they have a low cognitive test? And then once you go through all that, we can go down to this bottom section where it gets risk stratified kind of in the following way. On the left, you got the green arrow, at the bottom, you release, continue to drive without restriction. On the right, driving, retirement. And in the middle it's all kind of needs risk stratification. And where people fall on that kind of depends on what their risk factors are, right? So if they have mild dementia and have like none of those risk factors, they're falling on the left. If they have mild dementia and they have several risk factors, they're all the way on the right. And then there's the people in the middle with the yellow arrows here. And I'm going to talk about some of these risk stratification things that we can do to better risk stratify these people in the middle where we're not quite sure. It's not quite as obvious whether we should be concerned or not. I do point out at the bottom, consider at least temporary driving cessation while you're trying to figure this out. So let's talk about some of so first the high-risk drivers, the ones on the right. Recommendation for high-risk drivers should be surrender of driving privileges. There's an art to this conversation about restriction. Patients don't like it a lot of times. And so if you can word it better, it can make a difference. It is recommended we use terms like retirement from driving rather than saying license revocation or license suspension or loss of driving privileges. That doesn't sound as good. Ultimately, though, the restrictions must be communicated to the state transportation department, and we're going to talk about how you do that at the end. That's the ones on the right. So, some online resources for patients. I put this in here right now, partly because some of these resources can help with this conversation that can be difficult. Particularly these resources, the ones on the top, the National Highway Traffic Safety Administration website material has some material for patients and safety or family members that can help them kind of understand the risks. That same website has some material that can be helpful for providers too. The fitness to drive test is the second one. That's an interesting one that can actually be. I've never used this before, but it's a test that you can. It's actually a test that's out there. Here, actually, I can go to it here. This is it. It was generated, or it was created at the University of Florida, and it's for family members to take. And it has a bunch of demographic information, and it has you go through like your rating of your loved one's driving ability, and it'll spit out some information at the end about their risk level. And sometimes it can help family members understand why we're concerned and how concerned we should be. I've never actually used. I mean, I went through it. I tried it out just to play with it a little bit. I've never actually used it on a patient though. And then, of course, the last the last link here is just the Idaho DMV page. There's not much that's all that useful in there, except for some practical information sometimes if they're trying to figure out what they got to do. Okay, so back to what I was talking about before. We talked about the high risk drivers on the right. Now we got the low risk drivers all the way on the left of that continuum. So I point out when I'm talking about the low risk drivers that restriction other than surrender of all driving privileges may be appropriate. This is something that sometimes people don't realize. You can restrict drivers to various things that that might seem safer than unrestricted driving. For example, daylight only. No driving at higher speeds. You can put a radius restriction in there, and that's a little bit nebulous. It's hard for a patient to know what the radius from their home is, but basically if you're giving a radius restriction, that's a patient who you're saying, yeah, you can drive to these like 3 places that you normally go to, but that's it, kind of thing. And you can even put a restriction on time of day they can drive other than daylight. So there are restrictions you can give other than just no driving. And this reassessment is recommended at 6 months intervals, comes straight from the American Academy of Neurology guidelines. So now we got the ones in the middle, where it gets a little bit messier. The ones where we're not quite sure whether they, from just the initial assessment, whether they should be driving or not. So there is some risk stratification we can do, but first, if possible with these ones, the best case scenario, if we're not sure, is just for them not to drive. So if you can do that, encourage family member support to do alternate transportation, try to get them to voluntarily surrender the driving privileges in this situation. Maybe that can save us trying to figure it out, and definitely would be a good option. And then we consider, and then this third bullet is the risk stratification that we're going to go through. And then don't forget, of course, that restriction other than surrender of all driving privileges may be appropriate, and reassessment is recommended at 6 months. 2 things I just pointed out on 2 slides in a row. Okay, so for risk stratification, one thing that we can do, if we're not sure, is have the DMV test them. This isn't on, the DMV can do a state, well, the DMV, as you know, has a written test, and that actually can be good too. If the DMV requires patients with significant cognitive issues to do a written test, a lot of times that will suffice and screen them out, and you don't have to do anything. But a lot of times that doesn't help. You're still having to figure out whether they can drive. So you can do a skills testing, or on-road test driving test, or an on-road driving test. And this is the same test that the DMV offers, or the DMV makes you do when you're 16 years old and getting your license. It's the same thing. It may be requested by any examiner who is might be recommending driving restrictions or is concerned. And it must be formally requested by a medical professional. So the patient can't decide that they're going to do that on their own. I don't know why they would, but we have to recommend it for it to be done. It's 30 minutes long, and it may not be adequate. There's like a checklist of things that happens in this test. It involves street parking and backing, parking lot driving, business and residential driving, freeway or highway driving, 4 right turns, 4 left turns, 8 intersections, a curve, and a lane change. Has to meet all those criteria. If the patient can do those, they'll pass. Maybe that's adequate. You could also refer someone for neuropsych testing. You can get neuropsychology testing might make some commentary about driving, especially if you ask them to. That is an option to kind of help you determine what's going on. This is not one I've ever used in this situation, but this is something that might be available. I wrote, do not write the words driving anywhere in the consult. The reason I wrote that is that sometimes insurance doesn't want to pay for neuropsych consultation if you are doing it specifically for evaluation of driving privileges. I don't know if that really matters. It's probably fine to put that in reality. Even though I wrote that in capital there, that's probably not even true. Okay, so the last thing to mention for risk stratification is the most helpful one. It's It's the gold standard. There is a such thing as a professional driving evaluation that is specifically designed for this scenario. It's not just for patients with dementia, it's patients with all manner of issues, whether they be motor issues or whatever issues that they're having. That maybe a lot of times it's because they had a stroke and they have some issues with some mild hemiplegia or whatever. So you can send them for a professional driving evaluation. It's not very widely available though. It's generally going to be performed by an occupational therapist. Not just any therapist does it. There's only a few that have been trained to do it and are willing to do it. It's often not covered by insurance or partially covered. I'll talk about what that means. And the cost out of pocket is going to be quite a bit, actually, for the patient. So that's a problem. It's kind of hard to get a patient to go in and do that when it's going to cost them, and it might mean that they can't drive anymore. But it can be very helpful. It involves usually two parts. They do in-office testing, and they do some or all of these things on the left to help determine whether the patient is safe to drive. And if they pass all the stuff on the left and determine that they can graduate to the on-road driving, then they'll do on-road testing too. And here are some. So where are these things available in the state? Well, if you're in Boise, there's a couple options actually. St. Luke's offers it. St. Luke's Rehab. They have an outpatient neuro driving program. And there's the phone number. It's Kim Hendrickson that does it. The thing about the St. Luke's program, though, is that they do not bill insurance for any of it. So that is a pure. If you go through their program, it is purely out of pocket for the patient, and the cost. I don't know what it is now. When I was in Boise a few years ago, it was close to $500. The other option here, ADA Therapy Services over in Boise as well. They only do the in-office part of it. They don't do the driving part. So they can do the in-office part and then refer them either to the DMV to do the on-road driving part, or you'd have to recommend that, or you could also have them go over to the St. Luke's program to do the on-road part. The ADA Therapy Services program does bill insurance though. They will bill insurance for, all they do is the in-office part, but insurance they will bill, and insurance apparently generally covers it. So those are the options in the Boise area. Over here in East Idaho, we're pretty limited. We used to have a program in Pocatello, which no longer is here. So we got nothing. There is one in Idaho Falls at Achieve Therapy that you can use. And there's their information. Achieve Therapy does do both sections. They can do the in-office and the on-road section. They only bill insurance for the in-office portion. To do the on-road section, it is out of pocket for the patient. Okay, so how do we communicate with the transportation department when we are concerned? So first of all, as far as HIPAA considerations go, a release of information is not technically required to submit to the transportation, to submit a report to the transportation department, as long as it is submitted in good faith due to it being a public health safety concern. I'm gonna go through this form here in a second, and it does have a section for the patient to sign. Ideally, you have the patient sign that, but they don't have to. You can submit it without the patient's signature, because some of the HIPAA considerations we normally consider go out the window a little bit here due to just being a public safety concern. So the phone number is listed right here. This phone number is it's not the Idaho Transportation Department. This phone number I listed is actually the Department of Motor Vehicles within the Idaho Transportation Department. And if you need to call and questions or talk to them, there's a records desk there. And they can help answer questions there. It's also called the medical desk or the records desk. And actually, you don't have to ask for it. When you call, there's a phone tree and you can find your way to it. But this is the form that they do all their communication, that we do all the communication through. This form oftentimes will find its way to you when the patient comes to see you. So if the patient got in an accident, for example, or they had some sort of citation and the officer was concerned about their cognitive ability or whatever, their driving abilities, they may get their license suspended, and they will come to you with this form, and they're wanting you to fill it out to clear them to drive. So that is one way this form might come to you, is not because you sought it out, but because the patient brought it to you. But this form is also available through the transportation department if you are the one that's concerned, and this is how you would communicate with the transportation department as well. I'm going to zoom in on it here. This is the section we fill out, the medical section. It's basically, there's not much to it. You can see you're right in the top section what the observed concerns are, and then you put whether or not there's evidence that there's a problem, and then you put what your recommendations are. And as you can see, as I mentioned before, there are restrictions other than just not driving, right? Daylight only, no freeway driving, certain radius, and you can write that in down here, or you can just write no more driving, like suspension of driving privileges, if that's what you think should be the case. And then at the top, there's a fax number, or you can fax it to. And again, the phone number, you can always just call the Idaho Transportation Department. You can get that phone number off of the internet, and you can drill down to the DMV and the records desk, and they can answer questions you have or help you get the form. You need the form. Getting the form off of it is possible to find the form on the transportation department website. It's kind of hard. So you may have to call them to get it. Okay, so some strategies for family members. Obviously, it's a little bit hard to get patients to stop driving sometimes. So sometimes if we communicate to the transportation they're not supposed to drive, but they still drive. So some of the things that you can do to prevent that might involve a little bit of strategizing with the family members. So first of all, the family members, if you and the family members can work together to find alternate forms of transportation, that can make all the difference. But taking the keys away from them, one thing that I've never actually seen done in practice, but I heard of, which makes a lot of sense, is rather than taking the keys away, you just disable the keys, and then they're less anxious that they don't have the keys, but you've filed them down so that they don't actually work in the car anymore, and the patient gets less anxious that they don't have their keys. Or just remove the vehicle. So, made it to the end. In summary, self-reporting at the DMV is pretty much the only line of defense if we don't investigate. As I mentioned early on, there's not a whole lot of guardrails that come up as patients get older automatically at the DMV. They got to come in a little more often. They got to do it in person, so their eyes are getting checked more often. But that's about it. Otherwise, if they're not self-reporting, we're like the only line of defense. Or the family members. The family members hopefully are helping too. High and low risk drivers can be identified and dispositioned in primary care. It's going to be hard to refer everyone out if you're for this. Obviously you can, but it's depending on where you are in the state, that can be difficult. For example, getting neurology involved over here in East Idaho is not going to happen anytime soon. And then restrictions must be communicated to the transportation department. And that's what I got, but we have time for questions.
Dr. Christensen, I have a comment. A few years ago, we did have an OT here in Pocatello who did do driving examinations. She's no longer here, but I remember a conversation that I had with her where she indicated that it was very important that I word the referral appropriately. And I remember her specifically saying, don't put in driver testing.
Okay,
so I would urge anybody who's going to be making these referrals to call that office and ask them how they want you to word the referral.
Although I suppose it doesn't matter if you're using the St. Luke's program because they won't bill anyway, but yes. Dr. Crete.
I've got a quick 88-year-old we could go through if you wanted, take a couple of minutes.
Sure.
Could you pull the CDR slide up? Would that be easy?
Yep. Wouldn't be hard at all.
This is a physician.
Okay.
neurologist, he's 88, and he wanted to take me fishing,
Okay.
which I was suspicious of, and we got in his car and we got on the freeway, and things started happening.
Okay. So this is a good one. Does he ever drive with family members or anything? Are you the only person that's ever been concerned? That would be my first question.
His girlfriend doesn't get in the car with him anymore.
Okay. This one actually seems like it's kind of a slam dunk. What kind, do you know anything else about this patient's, like, is there any, like, functional issues, like IEDLs that he's needing help with?
Yes, he recently broke a leg because he fell down the stairs. And I took him some food each time, and I will no longer sit on his couch because he had trouble putting his pants up.
Okay. And if we drill deeper, you probably have trouble with all kinds of IEDLs, right? Like meal preparation or financial management of finances or
His finance,
keeping the house up.
he got me some music tickets
Okay.
for performing arts, and he organized that, and the amount of money that's involved. He's given money to this. He's very good on, actually.
Okay. So sounds like he's, and then if we did some cognitive testing, this is probably someone that would fall out in the middle somewhere.
He's moderate. Yeah.
So we'd probably have to do some sort of risk stratification.
He's had 2 crashes and totaled a car.
Wow. So this actually, let me go to, where's the slide that I wanted to?
I had 2 crashes.
This slide here. This is a great opportunity to point out that if a patient is in the moderate risk category and they need further risk stratification, the first thing I would try to do before I even do any of that risk stratification is try to get them to stop driving before I do it. Because this is someone who would be better not driving without knowing anything else.
Well, let me give you some more. We're on the freeway on the way to try and get a fishing license, and we're coming up, and there's a police car that's parked by the right-hand side. He's giving a citation. He's just finishing, and I say to him, "You got to move out of lane, because that's what you have to do. You're required to be 1 lane away from a policeman who's giving." He said, "I'm okay where I'm at." "No, you've got to move over to a lane." So just as he goes past the police car, he kind of weaves out in front of a large truck. And he says, the policeman saw him and stopped him.
Perfect. Good.
So it's your fault.
And he said, "You were weaving and you didn't go outside the lane." And he says, "Oh, sorry, officer." And I say to the officer, "I'm trying to keep him safe." And he looks at me. He doesn't give him a citation,
Uh-oh. Too bad.
and we carry on.
That would have been an opportunity for the state to intervene a little bit there. They could have required him to fill out get that form completed by his doctor before they could drive.
So what I elected to do was to phone his family physician and say, "You need to make a report to the Idaho Transportation Division and get him off freeways. Maybe he can go to Albertsons and get some food." That's what I did.
Yes, I would agree. That's probably a good assessment. That's probably, so it's a judgment call is how it falls out. And that would probably, I think that judgment would be good. I think that's probably where he falls out, although I don't know enough about I don't know whether he possibly shouldn't be driving at all, but that would be something that would need further evaluation, right? That'd be a great opportunity to get him, if we had a professional driving evaluation here, get him to do that. Or you could require him to do the DMV's test and see if he passes that. That actually might work pretty well in this case. Costs $20. And someone from the DMV will have to drive with him and do that checklist with him.
I was pissed at his girlfriend who should report.
endangered your life.
I went on a home visit one time and decided that I would conduct my own driving test with this elderly patient.
Okay.
And that's the only time that I have done that, and that's the only time that I will do it, because she very nearly got us both killed.
Yeah.
So I don't recommend that.
Yeah. So the professional driving people do they do the cognitive stuff first, and frequently I've referred to professional driving before, and I think in every case I've referred, they didn't do an on-road test. They failed out of the in-office test and didn't doing an on-road one. So that's frequently how they keep themselves safe. But I don't know how. I guess if you're a DMV driver and we refer for that, they must just have. I don't know if they have the ability. They have a brake on their side of the car, I think. I know actually they don't, because I think they do it in your car.
It's gotta be in your
I
own
think it's
car.
in your own car. Yeah, that's true. They do it in your own car. So I don't know how they keep themselves safe. That seems like a high risk job.
So our only option is to send them to Boise then for these driving?
Well, Idaho Falls. There's one in Idaho Falls.
Okay.
On this side of the state. I don't know what there is in like northern Idaho. I didn't actually even look into it. I probably should have, but.
So do we think that they have fitness middle category or severe and that they should be restricted and need a formal driving test?
I mean, it depends on, every case is different. It depends on what's going on. But yes, if they're kind of in the middle and you are not sure and you need something to help you, I think this is a great case. Like, this patient definitely shouldn't be on the freeway that Dr. Cree was talking about. Highway driving is definitely out of the question. Whether he should be driving at all probably really does need some more risk stratification, I would think. And a great way to do it would be either a professional driving evaluation or use the DMV to evaluate him.
Okay.
The point is, you've got to take responsibility for this. We actually have a responsibility to keep the roads free, and it's not just this, it is people who come in who had seizures.
Yeah, and we could, this lecture would be a lot bigger if we were just talking about driving restrictions in general. I'm just talking about the context of cognitive issues, but there's seizures, vision issues. Like I had a patient just the other day who assured me she has macular degeneration, and she assured me that her ophthalmologist knew that she was driving and was fine with it. When I called his office, that was not true.
There's a responsibility here you've got to take seriously.
So on that note, your responsibility was as a friend, and then, we're talking as like a primary care physician.
That's why I call this position.
What about, okay, so you call it physician, so then like hospital setting, you're discharging a patient, that would be part of your discharge recommendations, things like that. But
So
like,
another good example where this comes up that you bring up is a lot of times your patient's spouse is not your patient, right? And so if you may have concerns if you're seeing the patient and the spouse is with them and the spouse is driving and you have concerns about the spouse because of the patient's saying or because the family members are saying, but that's not your patient. So you may need to communicate with that patient, that your patient's spouse's physician to get something done.
The other thing that makes this a complicated issue is that there are a constellation of physical things, not so much vision and hearing.
Yeah.
Other physical limitations that don't necessarily render someone incapable of driving.
Right, and one of the things, man, it's funny because I was just talking to my mom about this last night because I have a relative who's 101 who still drives. And my main concern there is being 101 doesn't mean you can't drive, but your reaction time does get slower as you get older. That's just true. And so freeway driving at least is a little bit concerning for someone that age. Even if everything else out, notwithstanding everything else, freeway driving may not be a good idea when you get to be that age, just because you don't have the reaction time for when things are coming at you that fast at that speed.
One thing that's important to keep in mind is that we are a car culture, and anything that we do, not that we shouldn't, because this whole discussion has been about when we should intervene, but I also think that we have to really recognize what a terrible impact that has on an individual at a whole bunch of different levels. Not to say it's not the right thing to do, but it has impacts.
Yeah. Yeah, and enlisting families help with that helps, but sometimes that's just doesn't exist. It can be a really hard conversation and heart-wrenching to talk to the patient, but it's what's got to be done has got to be done. The problem is that a patient who I can't get help from the family, even if I communicate to the transportation department they shouldn't be driving and they get their license revoked. That's also a patient that I have no way of knowing that they're not still driving, because I don't have anybody on the ground there preventing them from actually driving their vehicle.
So big freedom to take away from people.
As far as logistics, is it best to track down that form at the get-go? Or like in the past, I didn't know how to get the form, so I just typed something on letterhead and faxed it in.
So if, yeah, so you can do that. If you have the number, if you can get the number, you can just fax something into the DMV and they may accept that, or they may send you the form and have you fill that out. Yeah, if you send something to DMV, they're gonna respond. So you can do that, that's fine. But there's a pretty good chance they'll send you the form. So if you can get the form to start with, that's better. Oh, one other thing about the form I forgot to mention. So this is new within the last few years. It used to be that it was just like you sent it in and that was the end of it. So if you send it in now and the patient hasn't signed it, the patient has the opportunity to basically appeal it by being able to take it to another doctor before it becomes written in stone. So that's another thing that can happen with it if the patient doesn't like what you said.
I'm gonna change doctors.
Unlike you. I like you more.
Other questions? I'll just wrap it up.
Thank you.
Nicole.
Thanks so much, Dr. Christensen. There are no questions in the chat.
Thank you.